Hello everybody, I'm Bill Shields and I'm here today to talk to you about ED Ocular Ultrasound. We'll be going over some of the basics of ED Ocular Ultrasound and how we use it in common eye complaints. For any questions, please feel free to reach out to me or contact us on our Twitter page. So, today we're going to go over a short introduction into ER Ocular Ultrasound. We're going to go over indications, the basic technique, sonoanatomy, and pathology. Introduction. So first, a little history and background on ocular ultrasound. So the first published paper on ocular ultrasound was in 1956. This was by Munt and Hughes. And basically they were looking at something called an A-scan, and they were using something what at that time they called a reflectoscope. And basically an A-scan was just a single ultrasound beam that was sent from the transducer through the eye and ended up receiving back the series of spikes which are proportional to the return of the echo. And so this was how early ultrasound and eye ultrasound was first being used. And then they got a little bit more advanced and started using something called a B-scan, and by the 1970s this became much more accessible as this was a handheld device. There are 5 standard views for the B-scan, and you'll still hear about the B-scan being talked about and used by our ophthalmology colleagues. However, at times MRI and CT replace some of the use of B-scans, but they're using very high frequency transducers to look at the anterior chamber, to look at things like glaucoma or anterior chamber tumors. So that's kind of a little bit of the history on this, but by the early 2000s is when emergency medicine really started adopting this, and lots of literature came out in the emergency medicine field. So first of all, is ultrasound safe for the eye? Yes, we know it is. But you always have to be careful when scanning anything, and we always want to apply the Alera principle, or better known as, or stated as low as reasonably achievable, meaning that you would use as little power as possible to ultrasound something. But to help ensure this, you always want to make sure you use the ocular presets, one to ensure safety, but also just to make sure you have the right settings to view the eye as best as possible. And to this date, there is no data to support any danger to the eye with eye ultrasound. However, again, we just have to be cognizant that we want to be as safe as we can for the patient. And also to ensure ultrasound safety for the eye, we always want to make sure we're using a proper technique. And this goes especially with placing pressure on the eye, especially when there's potential for ruptured globe. We really have to make sure that we're not pushing too hard on the eye, although there is good evidence out there showing that when people ultrasound the eye, they're not placing very much pressure on the eye itself. So let's go over some indications. So think about your typical patient when they come into the emergency department with an eye complaint. There's a lot of things that we do. We take a history, we usually get their visual acuity, we end up using the tonopen, take a look with the ophthalmoscope and a slit lamp exam, and these are all pretty much standard of care, but I don't think there's any reason why we can't incorporate the ultrasound when you find it necessary. Now, I'm definitely not advocating that every patient with an eye complaint needs an ultrasound, because I definitely don't do that myself. However, I think it really can add to the patient's care. I would argue that some of the devices shown in this picture are more difficult to use for an ER physician than the ultrasound probe. Our training is only so extensive, and we get to only do so many views of the retina, and I suspect that you will probably see more eye complaints that you'll be dealing with directly if you're working at a non-academic center once you leave residency, and I have a feeling you'll be more comfortable at times with the ultrasound. So I suggest that you consider using it when you think it could add to your patient's care, help with diagnosis, and communicating with your ophthalmologist. And again, in the acute setting, it's pretty reasonable to be doing this. And one last point about this too is that there are a lot of settings where you don't have access to an ophthalmologist. This is even true in our own hospital system, where we can't talk directly to an ophthalmologist, and ultrasound can really enhance what you're doing with the patient. So what are your indications here? So indications are acute vision changes or any kind of blurriness or loss of vision, You can consider using this in someone with a headache to look at things like the ophthalmic nerve sheath, to look at signs of intracranial pressure elevations. And anytime there's trauma to the face or you can't see the eye, for instance, in the patient here in this boxer, you would not be able to see their eye very well. Potentially at some point the eye might be so swollen shut you can't check pupillar reflex or ocular movements, and trauma would be a patient where trauma patients are a good group that you can scan to look at these things. You can also consider it in patients of altered mental status who can't really tell you much about their vision, and when your history and your exam is leaving you without a definitive plan or diagnosis, something else to consider. So what are your contraindications? First of all, if you have a cooperative patient, they're not going to be able to sit for an ultrasound. You don't want to potentially harm someone with it by holding someone down. So obviously you don't want to use ultrasound in that situation. An obvious globe rupture, ultrasound really won't add much to your plan. If they clearly have a globe rupture or an object sticking out of their eyeball, you leave that for the ophthalmologist. And if the ultrasound won't change management. But still, this doesn't replace an ophthalmologist, your ultrasound, but it can still help you with your exam. So let's go over the technique. So you'll want to use a linear probe. The linear probe would be ideal for anything superficial. So it's a high frequency probe. You'll be wanting using this in the ocular settings, as I kind of mentioned earlier, and follow to the Olera principle. If, for instance, you have a broken linear probe or vascular probe, or it's out of commission for whatever reason it's being used and you really want to use something, you could also use an endocavitary probe. It's a very high frequency probe, a little awkward to hold given its length, but in a pinch you could definitely use this as well for something very superficial such as the eye. So what do you really need here is the objects you see. You need gel and lots of it. You need a towel to help clean the patient up when they're done. I tend to give them a little towel that I place in their hand so they can kind of wipe gel away from their face as it drips down, and to let them wipe away the gel at the end of the exam, and plus or minus a tegaderm. So I tend to ultrasound patients without a tegaderm over their eye, but the idea is that you can put the tegaderm right onto their closed eyelid and then put the gel on top. I find that you get some air bubbles in there and makes the image a little less clear, but I tend to give the patient the option to see if they'd rather wear it. Some of them want to wear it, some of them don't. But we know that gel on the eye is quite safe. It might cause a little burning and irritation. Having had these done on myself for practice, I can tell you it irritates the eye a little bit, but it's relatively mild. And before you do any type of exam, I'd recommend using some analgesia, primarily a topical ophthalmic solution such as proparacaine to help kind of make the exam a little bit more tolerable. And of course, if the patient's in a lot of pain, anything you need to do, Motrin or something a little bit stronger to help get the patient more comfortable for your exam. And then what's really important, I think, is actually explaining the procedure to your patient. Here I am describing to Evelyn what she needs to do for this procedure, but really it's quite simple. You have to let them know that you're going to be placing gel on their face, that you're going to want them to be holding still, and you're going to be asking them to move their eye in multiple directions, just so they're not all of a sudden surprised when you're doing this. Just kind of makes for a little bit smoother of an exam. So when you position your patient, they can either be supine or upright or somewhere in between. A lot of times I'm doing this in like a dental chair or like a recliner, and so usually the patient's kind of around 45 degrees, and that works just fine. But obviously the positioning might be limited due to the patient's body habitus, what kind of bed they're in, or if they're a potential trauma patient and they're in C-spine precautions. But this should really be able to be done in anyone in really kind of any position. As always, you should be scanning on the patient's right, but before, when you're doing this, and before you start, you want to make sure you get a good amount of gel on the patient's eye. You want to make sure their eyelid is closed, of course, but of course you could also be using a tegaderm underneath this gel here. When you're scanning a patient, you should be using your hand to stabilize yourself. Here you can see kind of using the pinky to kind of bridge yourself. If you're scanning on the other side, you can use the bridge of their nose. But whatever you want to do to kind of stabilize yourself, just so you make sure you're not pushing hard onto the eye. Here you're noticing that they're scanning in both transverse and longitudinal, in two planes, as we should with every exam. You should not be holding the probe like this. Notice how your hand is kind of away from the end of the probe. This is going to make it more difficult to hold your probe still and more likely for you to actually place some pressure on the eye. So try not to hold the tail of the ultrasound probe. So don't do that. You might create too much pressure. So what does a complete exam entail? It entails looking at both eyes. It entails looking at both a transverse and longitudinal view. I admit I'm not the best at looking at both eyes. I kind of tend to go right to the one that's having issues. However, in good practice, especially if you're learning, I'd want you to look at both eyes and make sure you scan through the entire eye. So you kind of make sure you fan all the way in the longitudinal and transverse planes so you can get the entire view of the retina and the posterior part of the eye. And then you also want to make sure that you really consciously think about looking at the material in the anterior and posterior chamber and also the optic nerve sheath. And we'll go over this in a second. You also want to look at the eye when it's sitting still, but also dynamically. What that means is that you want to look at the eye and actually record images when the eye is moving, and we'll show why later on. And then you also want to make sure you do some overgain, which actually means that you'll be turning the gain way up for a couple of images to help localize and evaluate for potential pathology. So let's go over exactly what this looks like and some of the anatomy. So here's the relevant anatomy that you'll be looking at in the eye. You already know what these. You already know the anatomy of an eye from medical school and just from emergency medicine. But the things that we pay attention to in ultrasound are the cornea, the pupil, and the iris. You look at the optic nerve, and the sclera, retina, and choroid are really not something you can discern between. But in a normal, healthy patient, you can't really tell. You can't really separate these. In pathology, though, these could potentially be separated. And so, again, I kind of consciously looking at the anterior chamber and the posterior chamber. Most of what you're going to see is in the posterior chamber, but really consciously look at the anterior chamber so you don't miss something, like a lens dislocation or a foreign body that's unexpected. So here's just a still image of what a standard image should look like. Notice the anterior chamber up here. You'll see the eyelid on top. Actually, there's some gel on top first, and then you see the eyelid. You see the cornea. Right behind that is your iris, and then your lens. And so all of this is your vitreous humor of the posterior chamber. Back here would be your sclera, retina, and choroid. And of course your optic nerve coming back. And this is how you should start every image. Notice how the vitreous humor is black or nice and dark. That's kind of where you want to set it. If you need to adjust your gain a little bit, go ahead and do that. But that's a good rule of thumb, is that any fluid on any ultrasound really should look black. So a blood vessel, fluid in the bladder, and even fluid in the eye, okay, should all be black. Next, so here's another image of all that labeled. It's kind of the lid, the cornea again, everything else I just mentioned. All right. So if you're able to, you can kind of adjust the plane of your ultrasound, and we'll show this in a second, but you can also really make out the iris and the pupil. So here's what a standard image would typically look like. This is me scanning my own eye, but basically you see the gel on top, the lid, the cornea, the iris, and the lens, and the vitreous in the back. Notice there's a little bit of artifact here. It's probably because there's a little bit of air and impurity above, but this is pretty typical of the eye. They get these little artifacts coming through. You know it's artifact because it comes all the way through the eye, but this is a standard kind of picture of what you might expect for a normal looking eye. Notice that the eye is looking in all the directions, kind of making sure you kind of see all the way through it. And then you should also make sure you actively fan through the eye. So here I am fanning superiorly to inferiorly and inferior to superior to make sure you're looking at the entire back of the retina. And then once you've done that, you really want to turn up the gain. Notice how this is nice and grainy inside of the eye. And so once you've looked at the eye in a normal gain with a black vitreous or humor vitreous, make sure you really turn up the gain to make it kind of gray, and this will help bring out extra or potential pathology, which we'll show. So those are all kind of the normal things that you'll be doing. Again, both eyes, two different planes, fanning through it and turning up the gain. So let's talk about the pathology, which is the bulk of the remainder of this talk. So again, kind of really have a plan when you're doing any kind of ultrasound, and kind of train your eye what you're going to look for. But you first want to look at the anterior chamber. So again, what can we find here? Not a whole lot actually for emergency medicine, but when are you going to be doing this? You're probably doing this most likely if someone has trauma to their face, um, uh, obvious lid swelling, someone who can't really comply with an exam. And so you want to put a lot of gel right on top of the eye. Now again, if it's an obvious globe rupture, no reason to do this. But if you don't think there's a good chance of a globe rupture, I think it's safe and reasonable to look. So what you'd be doing is you'd be placing a probe on the patient and asking them to look in all directions. And you can see from this person, you can see that they have their extraocular movements are intact. So I think you could be reassured by that. The other thing you can do is check someone's pupillary reflex. So if you can't get access to their pupil, you want to at least kind of see if their pupil's working. What you would do is shine a light in their contralateral eye while imaging their iris and pupil and making sure it constricts. So this person clearly has an intact pupillary reflex. So this is a scan that I did, not as clear, but I'd say this is more typical. You can see that as you're shining light in the contralateral eye right by the pointer, you notice the pupil clearly constricts there, and so this pupil is also working. So typically you'd be scanning a patient like this, right? Your ultrasound probe would be perpendicular to the eye. However, that really doesn't get you in the correct plane to look at the iris and the pupil. So what you have to do is have someone look up and you scan from below a little bit while someone uses the light to look in the contralateral eye. This gets you a little bit more in a frontal plane so you can actually look at the lens and pupil. A little bit difficult to do, but it doesn't really take much practice to get good at this. So what else can we be seeing? So here is an example of a lens dislocation. So this kind of goes along with the anterior chamber and also posterior chamber. So we're going to transition from front to back. So basically here on the right is what you would expect. You'd see a lens right behind the iris here. However, here there is a lens clearly floating in an echogenic vitreous here, and that's a sign of a lens dislocation. Clearly this should not be there. That should be up more on top. I've only seen this once. This is in the setting of a motor vehicle crash where something came through the windshield and struck the patient in the face. Fortunately, I don't have those images. So here's just a couple of examples. This is pretty easy to see. It doesn't really require much skill to figure this out, but you might not be able to catch something like a very subtle subluxation. However, if you see this clearly needs emergent ophthalmology consultation. So again, this is usually due to trauma. Could also be spontaneous in people with something like a connective tissue disorder. Again, and here's a video of it taken from the POCUS Atlas. All right, so what else can you see with the eye? So this is relatively easy for you to spot, I'm sure, as well too. This is an example of finding a foreign body in the eye. This is a BB with some ring down artifact. So metal are things that you're going to be able to see pretty good, and usually it's like a metal sphere like this. Glass you should be able to see. Might be a little bit more difficult. Your probe probably has to strike it fairly perpendicular to get a good reflection. But organic material such as like wood might be a little bit more difficult to see. If there's a high suspicion for something such as a foreign body and your ultrasound's not picking it up, you may need to go to something like a CT or an MRI or an ophthalmology consultation. This isn't a foreign body, but it's a sign. So I want to show you something else that you might be able to see in the eye. This is a melanoma of the eye. So just be aware of that. Other things might be picked up on. So clearly, if you saw this, someone coming in with vision changes, it's not for you to diagnose what this is, but clearly it can help speed along the patient's workup and process and kind of get the right team and patient hooked up with the right specialist. So next, we're going to get kind of more into the classical things that people find, the more common things that they'll find when they're encountering a patient with vision changes. So this is an example of a patient who came in with floaters. They had a little bit clouded vision. This is spontaneous, usually non-painful. It's an example of a vitreous hemorrhage. So this occurs in about 7 to every about 100,000 people, fairly common, something we'll see pretty common in our emergency department. What you see here, what you're seeing actually is like little fresh hemorrhages, which are represented by small little linear dots or densities that you see there that are hyperechoic there. they swirl as the eye turns, because that's just kind of the hemorrhage turning. People call that after movement. So everything that we'll see kind of from here on has some after movement. They all have kind of their more typical patterns, and you see this kind of swirls for a little bit. Kind of like, almost makes you think of like clothes in a washing machine once it stops. The other thing you could think about using this in as a child, for instance, if you're worried about something like child abuse or shaken baby syndrome, nothing I've done spontaneously, but this is one way you can visualize something such as a vitreous hemorrhage in a young child. So here's another example of it. This is probably one that's been a little bit going on a little bit longer or just a little bit larger. You can see the blood's a little bit more congealed in the posterior part of the eye, and as the eye turns, you still get some sloshing there, some movement, some of that after movement. And this is again a sign of a vitreous hemorrhage. And here's just one more example for you. So I'll take this time to say, if you want to look at other images of the eye or anything for that matter, you can go to something called the POCUS Atlas, which is the little logo here in the bottom right. I've actually contributed some images to the site. It's really nice just to kind of look at things if you're curious what certain pathologies might look at. Again, that's the POCUS Atlas. Here's another example here's a patient who I saw myself. Here they came in with some flashers and floaters, kind of changes all of a sudden. It was not painful, and this is typically what I expect. I see the lid, I see the cornea, I see the iris, and the lens, and here's the vitreous, nice and black. No separations of any of the layers in the back of the eye, so it looks pretty normal. But then what we kind of talked about earlier is you want to make sure you really turn up that gain. This is where you get that overgaining. So really dial that gain up. So this is the same patient. And now you can see material swirling within the eye on both sides. So this is how you might pick up on some pathology. This is an example of a patient who had a posterior vitreous detachment. Again, here's another example of posterior vitreous detachment. This one's a little bit more clear. You can see that the vitreous is no longer attached to the back of the eye. These can appear to have like a thin border, as you see here. They're mobile, they're pretty jiggly with movement. And if they're chronic, they might look a little bit more stiff and dense, however. And then one key to realize that the margins don't go to the optic disc, which would be at the back of the eye, and that's one way you differentiate it from a retinal attachment, which we'll get into in just a second. But if you see this, you don't have to necessarily diagnose what this is. If you know all the better, this is a posterior vitreous detachment, that's great. But really, once you see this is something you get an ophthalmologist for. So here's kind of a cartoon of how this might look. The key is that there's no attachment to the optic disc. Here would be the optic disc, and you realize that this is clearly not attached to it. So this is, again, a posterior vitreous detachment. So this is what a retinal attachment would look like. Usually it's anchored at the area of the optic disc, and also at the anterior portion of the eye up here. As you see, it kind of attached up here. It's called the ora serrata, and that is pretty indicative of retinal attachment. You can see how it's a linear but still wavy, serpiginous kind of bright or hyperechoic line here representing retinal attachment. Fairly easy to see. This is something you put the probe on. For the most part, you'll see it pretty clear. Sometimes they'll be a little bit more subtle though. However, like this one, this is an example of another retinal attachment. Doesn't all that look different than what a posterior vitreous detachment look like sometimes, but clearly there is a second line here above the back of the sclera, and in the right setting you might have a good chance of knowing what this is. Otherwise, clearly this is enough for me to prompt an early ophthalmology consult or transfer a patient depending on where I'm working. And again, this looks like the first one. This is just showing that the pattern kind of is pretty similar for a lot of people for a retinal attachment. This is again another retinal attachment. Here's an example of the retina attaching to the optic disc. If I pause the video here, you can clearly see it coming down to the optic disc. This is a good way of proving to you that this is going to be a retinal attachment. So again, kind of a cartoon picture, but you kind of see almost like this seagull sign here. It's kind of a cartoon here from EM Wrap, kind of showing how that would look. It never looks pretty different from a vitreous detachment. So this is something I've never seen before. I've only read about it, but it's pretty clear if you would see it. This is called a choroidal detachment. This is usually in something that you'll see after a patient who had some ophthalmologic procedure done. This is blood underneath the choroid. If it's bilateral, you kind of get this bilateral choroidal detachment. People call these are kind of kissing here. Clearly, if you saw this is some pathology, this is more for an ophthalmologist to manage, but if you saw this as something you could kind of describe to them very clearly. And here these are all, here's kind of all the main 4 posterior different eye pathologies we just mentioned. Here you see retinal detachment again, kind of wavy, but always kind of comes down back to the optic disc. Here's a vitreous detachment where you can see it's more of kind of a C shape, or concave C, kind of pointing upward, without attachment to the optic disc. And again, a vitreous hemorrhage, which would be just kind of bright echogenic material floating within the eye, representing blood, and again, your choroidal detachment. So we'll finish up with a couple other things. We're almost done here. This is a patient that I actually saw with one of I saw in residency. This is a patient who had an object come through a windshield, and clearly we couldn't see their eye. We have lots of gel here. They have a very swollen lid, and it's so much material in here we can't really make out the eye. And this is a pretty good sign this person has a ruptured globe. So this was pretty much the only image you would get. Clearly this is indicative of a globe rupture and emergent ophthalmology consult. This one's a little bit more clear. This is a patient that I saw with one of our residents. I'll go back to that. This is a patient I saw with one of our residents who this patient was struck in the face by an airbag. Patient had a very swollen eye. Notice the large amount of gel we have in this picture. You're not touching the eye at all. He was in a lot of pain. Large amount of gel here. You placed a probe on, and you clearly see the contour of the eye is very irregular. All you really need to do is see that. We just took 2 quick pictures. There's a lot of hemorrhage in here. This is a ruptured globe and requiring emergent ophthalmology consult. Not going to go over this in too much detail on the sake of time, but there are some data out there about looking at the eye for potential ruptured globe. The data is pretty reliable, showing that we don't really place much pressure on the eye if you do it correctly with lots of gel. But again, if someone clearly has a ruptured globe, you don't really need to do ultrasound just for your own satisfaction. If it's in question or you can't tell, or they have a swollen lid, or you don't have ophthalmology consult, or can't get other types of imaging, this would be one way to do it. So lastly, we'll get into looking at the optic nerve or optic disc. So here's obviously a patient with papilledema. And to kind of briefly go over this, there are upper limits of normal, and the way you measure the optic nerve sheath, it's not the optic nerve, but rather the sheath around it, is you measure 3 millimeters posterior to the eye, and then you measure directly across. And it should be less than 5 millimeters for most adults. And as you can see, for children and adults, the upper limits of normal are a little bit smaller. So this is my own eye. What you're doing is you just, again, you find a still, you see the optic nerve, and then you kind of see how there's this there's a little bit of a bright area with a little bit of a hypoechoic line next to it on both sides. And so that's the border of the optic sheath. So you're not measuring this hypoechoic center. You're measuring the sheath, which is on the outside, because when someone has elevated intracranial pressure, the pressure transmits to the sheath, and the sheath gets swollen. And so that's actually what gets enlarged. And so you measure the outside the sheath. And so you measure about 3 millimeters back, or 0.3 centimeters, and it should be less than 5. Again, this is a little bit more obvious, but you can see the edema to the optic nerve sheath here. And there's so much swelling here, you can actually see the optic nerve protruding into the back of the eye, and that's called a crescent sign. Here's an example of a patient I saw with a headache at Moreland Reserve, patient with a bad headache, and you can clearly see this crescent sign here, and the optic nerve looks dilated, and clearly is measuring greater than 0.5 millimeters. So a sign of elevated intracranial pressure. So that's it for now. It's a pretty easy exam. I want to say thanks for listening. Please email me with any questions, or give us a follow at our Twitter page there. And if you have any cases that you want to contribute, just let me know. Thanks again.